Thank you very much, Rick. I'm very happy to be here. Thank you for the invitation. I was a little bit intrigued by this topic because I'm not sure there's much evidence it's increasing in incidence, but it gave me a few thoughts to start the talk with. The first of which is, what causes CLL in the first place? What are the risk factors for developing CLL? And so this is a summary from a recent study from the Interlymph Consortium, in which they did a pooled analysis of 13 case control studies, 2,400 CLL cases versus 15,000 controls. And these were incident CLL cases. And you'll note that the top risk factor was a family history of heme malignancy, including any non-Hodgkin's lymphoma or leukemia. Other risk factors included having ever lived or worked on a farm, having worked as a hairdresser, having hepatitis C infection, which is well known. And protective factors included a history of atopic illnesses or sun exposure. And so we don't really have a lot. You'll note that the odds ratios for these risks are not that high. But in the case of the heme malignancy family history, this has been a very consistent risk factor across all studies, and it's probably underestimated in this study because it was not specifically asked of individuals with incident CLL whether they had a family history. If we look, for example, at Scandinavian databases, where there's good capture for both the probands and the relatives of hematologic malignancies, we see that the risk factor for having a relative with CLL in an individual with CLL is actually 7.5-fold compared to the general population. And risks are also increased for non-Hodgkin's lymphoma and Hodgkin's disease. If we look in registry-based studies, such as, for example, ours, the rate of reporting of first-degree relatives with a lymphoproliferative disorder amongst CLL patients is even higher, on the order of 12%. And perhaps about 2/3 of these report a relative with CLL. Of note is the fact that the population attributable risk, namely the percentage of CLL thought to be due to inherited susceptibility, is 35% for CLL, which is quite high. And the very low rate of CLL in East Asians is maintained amongst those who immigrate to the US, suggesting that this may be more genetic than environmental. Furthermore, we see in the literature many sample pedigrees of families like this. This is actually a family I'll talk about later in our own database. All of the affected individuals in the filled-in circles have CLL. And we see families like this with essentially Mendelian inheritance not uncommonly. And so in our registry that we've been running for 11 years, you can see that the reported frequency of first-degree relatives amongst probands with non-Hodgkin's, Hodgkin's, and CLL ranges from 6% with Hodgkin's up to 13% for CLL. And if you include a second-degree relative, they're all above 10%, and it's approaching 20% for the CLL patients. Amongst the CLL patients, we see predominantly CLL, but there's also a significant rate of non-Hodgkin's lymphoma shown in blue. And there seems to be a little bit more crossing over to the other diseases amongst the CLL relatives than we see in the non-Hodgkin's and Hodgkin's probands, which is a fairly consistent finding, and it's likely that there is a phenotype for both just CLL in a family as well as CLL and other lymphoproliferative disorders in a family. So what about this question of whether CLL is increasing? So this is from the SEER data, which really doesn't suggest that there's been much increase, maybe a bit of a blip in the 2000s, and deaths are really quite stable. I also queried the Mayo Clinic as to their opinion about this from their data, and they agree that we're not really seeing much increased incidence of CLL or familial CLL. But I think the question may have arisen because it does seem to me that, at least in clinical practice, I'm seeing more and more patients with so-called MBL, or monoclonal B-cell lymphocytosis, which is really only, it was identified earlier, but it really only became more evident and codified about a decade ago. And so these are individuals who have a monoclonal B-cell population, originally identified in residents near hazardous waste sites, but also found in normal blood donors. This led to subsequent studies of outpatients in clinic, where it's found that about 2% would have potentially a CLL phenotype clone in their blood with no hematologic disorder. And in those over 60, this number goes up to the 5 to 6% range. Depending on the sensitivity of the assay, it actually can approach 75% in 90-year-olds. So this is quite common. And unsurprisingly, in unaffected members of CLL families or unaffected relatives of individuals with CLL, we also see more of this at the 14 to 18% rate, with the relative risk highest in those who are younger, because this is less common in the general population at younger ages, like those less than 40, and becomes more common with increasing age, so the relative risk is less. So it suggests that this could be a marker for the CLL risk phenotype and potentially a marker of having susceptibility to CLL amongst relatives of those with CLL. And so this new diagnostic entity, MBL, monoclonal B-cell lymphocytosis, was defined in 2005 as consisting of having circulating clonal B cells, most commonly with a CLL phenotype. If it's not a CLL phenotype, it generally warrants additional workup. But the absolute B cell count is less than 5,000, and the patients have no other features of a lymphoproliferative disorder. Studies have suggested that all patients with CLL do go through a pre-existent MBL phase, but the prevalence of MBL is several hundredfold more than CLL, suggesting that most MBL cases don't progress to CLL. And so this led to a conundrum in 2005 because MBL was a B cell count less than 5,000, but CLL was a lymphocyte count greater than 5,000. But it turns out you can fairly commonly have a lymphocyte count greater than 5,000 and a B cell count less than 5,000. This is actually true at that time of up to 40% of newly diagnosed dry stage 0 CLL patients. So there was potential overlap of the diagnostic criteria. It turns out, however, that the B cell count of 5,000 is a better threshold in terms of predicting treatment for your overall survival than the absolute lymphocyte count threshold. And that's why, as you know, the IWCLL in 2008 changed the diagnosis of CLL to requiring the absolute B cell count of 5,000. And so this led to further studies looking at MBL across populations and really the definition of two categories of MBL. We have what we call population screening MBL, people who have no evidence of any hematologic problem who are screened with highly sensitive flow cytometry, and they typically have extremely low numbers of these clonal B cells, 1 per microliter on median, versus those who are typically referred for an elevated lymphocyte count, whose median count is about 2,900. And this is obviously much closer to CLL. And you can see that the distributions are fairly dichotomous, and the official cutoff is 500. So it turns out this low-count MBL has a very, very low risk of progression to heme malignancy. There's no difference in the rate of death or non-heme malignancy in these patients in a UK series, and no effect on overall survival. And perhaps unsurprisingly, given that, the biology of the cells differ amongst the low-count MBL from CLL. We more frequently see biclonal or oligoclonal populations that may come and go over time. There's a distinct IgH repertoire that looks more like normal B cells. So they're usually mutated, and they don't have the most common CLL V genes, the 434, 323, and 169, and stereotypy, where an identical V gene is found across multiple CLL patients, is very rare, as are high-risk FISH or CD38 or ZAP70. But what about the clinical high-count MBL? So in multiple studies, their risk of progression to treatment is about 1 to 2% per year, shown here in data from the Mayo Clinic. This is lower than for those with CLL B cells between 5 and 10,000 or greater than 10,000. And so differentiating this for your patients does have a potential prognostic impact in terms of outcome. As one might expect, the biology of clinical MBL is more similar to CLL, but on the favorable end compared to more advanced dry stages. And these are data, again, from the Mayo Clinic looking at the survival of clinical MBL versus CLL. In the upper left, you can see that the dark line is the survival of clinical MBL, which is not statistically different than the general population in that curve, whereas it is for those with Ry0 CLL with B cell counts above 5 or 10 in the upper right and lower left. But in the lower right, if you differentiate based on CD38, which was the primary prognostic marker they had, they didn't have adequate data on FISH or IgH. Those with the low-risk CD38 are equivalent to the general population in survival, whereas those with the higher risk are showing a worse outcome. So this suggests that the great majority, the 80 or 90% of patients with clinical MBL who have lower risk markers, do extremely well. There are a couple things to watch out for, though. The incidence of second malignancies appears similar to CLL, here 12 to 13% versus 4% in clinical controls. And again here, even controlling for treatment of CLL, the MBL and CLL curves in blue are largely overlapping compared to the clinic population in red. And there's also a higher risk of hospitalization for infection in high-count MBL versus CLL. Again, regardless of treatment for CLL in the right curve. It's 16 to 18% versus just 3% in the clinic controls here. So is MBL increasing? I haven't seen data to this effect, but it hasn't clearly been evaluated. My impression from seeing patients is that this may be identified more and earlier as we're looking at more CBCs routinely, and there may be a lower threshold for further evaluation, and that particularly this may be done in those with a family history, and so that we're seeing these patients more and more who come in with MBL but a family history. And I do think it's important to differentiate for the sake of the patient from a prognostic standpoint. Patients are very happy to hear that this is associated with a better prognosis than the higher actual CLL. And it's also important to stress, though, that they need the same supportive care as CLL patients, as we just saw, in terms of screening for second malignancies, vaccinations, and care about infections. Okay, so now I'm going to turn a little bit more back to familial CLL, and first just comment on whether cases with a family history are different at all from those CLL cases not associated with family history. Traditionally, we define familial CLL as at least 2 first-degree family members in a family who have CLL. And multiple studies have not found much difference in disease features between familial and sporadic disease in terms of stage of presentation, need for therapy, or overall survival. Even age at onset is not clearly very different. And there's not good evidence for anticipation, which is when the disease occurs at a younger age in subsequent generations. We looked at this in the CRC database a number of years ago and found that 14% of the patients had a family history of CLL amongst these referral centers, and 13% had a family history of another hematologic malignancy. So that's getting up to a quarter of the patients in this data set. Only 30% of the patients had no history of any cancer. The mean age at diagnosis was similar. There was a slight trend, but only a year different. And there were no differences in stage, beta-2, IgG, CD23, CD38, or ZAP70. No difference in the frequency at which IGHV was mutated. No difference in the selection of the V gene family. And recently, as part of our exome sequencing studies, we deliberately enriched this population of 160 patients for familial CLL cases. We had about 30%. And we looked at the distribution of mutation rates amongst those with familial versus sporadic CLL, and there was no difference. Similarly, the frequency of the most common driver genes was not obviously significantly different between the familial and sporadic patients, although a larger data set would obviously be helpful in this regard. So there's really little evidence for biologic differences between familial and sporadic CLL, although cytogenetics have not been adequately investigated, and a couple papers in the literature, including one of our own, suggests a lower frequency of 11q deletion in familial CLL. And we still need a large-scale analysis of outcomes in comparison to sporadic CLL, which we still hope to do through the CLL Research Consortium database. Now, if we think about what are the models of genetic causation for a disease like CLL, I think this is a very helpful diagram from a review by Holston's group a number of years ago now. If you think about it in relation to the number of cases in a family, if there's only one case, that's likely to be a sporadic event, or at most there may be some low-risk alleles in the family, shown at the left of the slide. And as more and more affected individuals occur in the family, it becomes less likely to be sporadic, low-risk alleles are present, but as you get up to 4 cases, for example, then it becomes almost Mendelian, and it's much more likely there'll be a very high-risk allele in that family. And so if we just write that out a bit, the high-risk alleles would have a high relative risk of the disease, but be very uncommon in the population. And typically, these would be identified by linkage. And linkage has not been that fruitful in the case of CLL because it's typically involved relatively small families with just 2 or 3 affecteds included, and not very large sample sizes. There is one notable family that was reported by Ohio State with a polymorphism in a regulatory region for the DAP kinase gene in that family, but not in any other CLL cases. In contrast, we have the alleles identified by genome-wide association study, shown at the bottom. These are common in the population. 10, 15, 20% of the population may have them. But the relative risk conferred by each is very low, often between 1.2 and 1.5 is on the high end of the risk associated with those genome-wide association study alleles. Still, we now have 5 genome-wide association studies that have identified up to 38 alleles, probably 30 or so, that are independent. And they're listed here. Most of them are not in genes or coding regions. They're mostly intergenic. And so the genes listed here are generally the closest gene. I've highlighted in blue some of the ones that might mean something from a biologic standpoint, like IRF4, MYC, IRF8. 2 of the more recent studies, which had very large numbers, thousands of cases, identified a number of apoptotic genes near GWAS alleles. And we only have 1 case of a somatic driver that appears to be involved from a GWAS standpoint, which was POT1. 10 of these have been tested as risk factors for MBL, and in fact, associations were observed for 9 of them, 6 of which were significant, which is potentially consistent with the idea that MBL is a precursor condition for CLL. Now, there's a lot of interest in figuring out what these genome-wide association study alleles do. They're highly statistically associated with the disease, but they're intergenic. And so the hypothesis has been that they're regulatory. This was a study that found altered expression of 2 genes near GWAS alleles. This was in normal B cells. We did a similar study ourselves in CLL cells, where we found a strong association with expression of the HLA-DQA1 gene, shown at the top, as well as FKRP at the bottom. Recently, I've tried to extend this to be more mechanistic, collaborating with Jay Bradner, where he has been using an assay called ATAC-Seq, which is a way of looking at chromatin accessibility with a transposase that cuts nucleosome-free regions. And we've looked at this in 15 CLLs and 5 normal B cells and compared regions of chromatin that look open or accessible by ATAC-Seq versus H3K27, which marks active enhancers. And so in the upper left, you can see that we find more of these in CLL than normal B cells, or NBC. And in the upper right, you can see that most of the 74,000 such sites across the genome have been described in other diseases. But 15,000 are unique to CLL, about 17%. So they could be novel CLL regulatory regions. And just to give you an example, on the lower left, we have the ZAP70 gene, where at the bottom in the NBC, which is the normal B cell, you don't see any significant spikes. So there's no expression of ZAP70, which we would expect because that's a T cell gene. Above it, we have a ZAP70 negative CLL, which looks pretty similar to the normal B cell, not much expression at all. But above that, we have in red a ZAP70 positive CLL, where you can see there are some significant spikes indicative of active transcription of the ZAP70 gene. And that's statistically significant in the lower right. So we used this to look at the 38 SNPs identified by GWAS in CLL. And the top picture here looks at where those 38 genes are in terms of regions of the genome. Are they in coding regions or untranslated regions in the top panels, which you can see very few of them are? Are they intergenic? Or the bottom 2 rows are the H3K27 and the ATAC panels. So in the top, with just the GWAS alleles themselves, we're not seeing major involvement of the hypersensitivity regions. We see about 12 of them overlapping with 38 SNPs. But at the bottom panel, if we look at all the GWAS alleles that are in linkage disequilibrium, all of the other SNPs that are in linkage disequilibrium with the GWAS SNPs, in other words, they could be the causative allele just as the GWAS SNP, because we can't really distinguish them from the statistical studies that have been done. There we see a very significant overlap with these regions of the genome that have open enhancers. And that's illustrated in the middle panel here. So this is the GWAS allele itself, which doesn't have open chromatin. And this is the linked allele, which is showing significant activity in the CLL versus the normal B cell. And here on the left, this is a random distribution of where we would expect these 38 SNPs to be if there were no selection for their association with the H3K27 or the ATAC. And you see they're black and black, so they're not significantly different. But if we look at all linked SNPs, they're very significantly enriched in these regions compared to a random distribution, and much more so than any other cell type. So this does suggest that many of these GWAS alleles may be regulatory regions. But what does this have to do with familial CLL? So the frequency of these alleles in familial CLL has not been explored in detail. We've looked at one of them where we found the same frequency in sporadic and familial CLL, both of which were higher than the general population. Recent modeling suggests that these SNPs may explain up to 50% of the heritability of CLL, but so far we've only explained 19%. And these analyses have had low power to detect loci with low risks or less common loci. So there may be other types of alleles, rare penetrant alleles that are similar to Mendelian alleles, or less common SNPs with modest to intermediate effects. And so whole exome or genome sequencing can be used to find these. It has the advantages of unbiased identification of all coding variation, common and rare. It's enriched in rare variants, but the statistics are challenging given the low frequency alleles and small effect sizes. And not even all coding variants may have significant effects. It's very difficult to address non-coding variation as well. This is a list from about a year ago of cases where next-generation sequencing has identified familial cancer genes, and it's mostly restricted to families thus far, not populations, and mostly Mendelian type inheritance. So we're doing this now, co-analyzing germline SNPs from 500 CLLs and 9,000 normals, focusing on rare variants. And I think we're almost there. I've been saying that for a few years. It's a hard problem, but I think we are getting there. And then we'll obviously need to evaluate candidates in terms of functional significance, second hit in the tumors, and concordance among family members. Another approach is to analyze family members for shared novel variants, but this is challenging because siblings share half their genome. So I'm going to conclude by saying, those are two families that we found, that lymphoproliferative disorders are commonly familial, the phenotypes vary. Shared genetic predisposition does not mean similar disease prognostic features. Linkage and association have not been helpful thus far. Families with Mendelian inheritance typically have a private allele. Common variation contributes somewhat, but doesn't explain heritability thus far. And we don't understand the biology of it, but we're starting to approach that with methods looking at regulatory regions. Source of remaining heritability is unknown, but we hope to find it using exome and genome sequencing. Thank you.